The show personalities and guest alone, and not those of Vic Canellis Media Group, its parent, affiliates, or stations. VCMG Live is not responsible for any content, information, or opinions expressed. User bears full responsibility for their reliance on such content, information, or opinions.
Amp2.tv presents You and Your Doctor, teaching you to live a longer and healthier life. Proudly sponsored by All County Healthcare, where people are the heart of our business. All County Healthcare is a Medicare certified agency where one call will service all your home care health needs. For more information, call 954-717-7027 or visit our website, allcountyhealthcare.com. Now, let's get informed to living a longer and healthier life. Here is your host for today's show.
Welcome back to another episode of You and Your Doctor, sponsored by All County Healthcare. We are a board-certified home health care agency. We are servicing Miami-Dade, Broward, and Palm Beach County. Our direct number is 954-717-7027. My name is Louise Gomez. Welcome to the show, everybody. And tonight we are lucky to have in the studio live here Dr. Kevin Palmer, who is a board-certified foot and ankle surgeon. I'll give the phone number. It's 561-241-4758. His address is 1905 Clint Moore Road, Suite 105, right here in Boca Raton, Florida, 33496. Welcome to the show, Dr. Palmer.
Thank you. Thank you for having me.
Absolutely. We're lucky to have you, and here to discuss a little bit more about you and your specialty, but give us a little background history about yourself. Where did you
I grew up in upstate New York.
Oh, nice.
Outside of Syracuse.
Okay.
We did a lot of water sports. We did a lot of snow sports.
Oh, yeah.
All year long. There were different types of activities. And then I went to University of Vermont for my undergraduate.
Nice.
And then I was in New York City, and then I was in Atlanta. And then I moved down to Florida and went to Barry University for my podiatry school.
Nice.
And then I did my residency down here, and I was in practice with one group since 2007, an orthopedic group where we did a lot of traumatic injuries at both Delray Medical Center, West Boca. And over the last year, I've moved to a different group, which is called Hand and Ortho, so that's where I'm at now.
Oh, nice. So at what point did you decide I want to be a foot and ankle, podiatry, foot and ankle?
Well,
when did you, during that time frame, when did you have that clear?
I've been around surgery and the medical field. My father's a hand surgeon.
Oh, nice.
And we have a bunch of different medical specialties in the family. So I was always kind of intrigued by the surgical side of things, and I was always fixing things, doing different things, building things. But as far as the foot and ankle, I applied to the different schools and I got in. I wasn't sure it was going to be the thing for me, but once I started learning about all the different anatomy and how complicated it is, it really kind of solidified that it was interesting. I didn't want to follow in the same footsteps. I wanted to do something different than what other people in my family did, but really enjoyed all the foot pathology, the complexity of it.
It sounds like a natural progression because it's like in the family, and then you said you enjoyed fixing things and very hands-on.
Yeah.
So it sounds like it was a good progression for you.
Yeah.
So, Dr. Palmer, what are some common what are some common ailments you might see in patients coming to see you on a regular basis?
We deal with a lot of arthritic type conditions, arthritis of various foot joints, ankle joints. We also see a bunch of tendon pathology. We see flat feet, we see bunions, contracted hammer toes, pain in the front part of the foot. We see some thinning of the skin.
I see. So a lot of different things.
A wide variety of pathology.
So, for example, some things people may not even be aware of that I don't even really know. What is it? Hammer toes and forefront pain. What is a hammer toe?
So hammer toe, you've probably seen people with the bunion that's sticking out of the side of the
Yes.
shoe.
Yes.
And they have toes that are contracted,
Oh,
or the
yes.
toes are overlapping the bunion.
Got it. Yes.
So a straightforward hammer toe is one that is just contracted straight up and down, and then you have some that are deviated from one direction or another.
Okay.
So there's various different types of hammer toes.
I have a question. So if somebody, when they're younger, they see they have this type of problem occurring, is there anything they can do? Because I feel, I may be wrong, but are bunions hereditary? I know my mom had it, my grandma had it. Is that
So-
something that is hereditary? Maybe we can work
So
towards...
usually, as far as bunions, you're going to inherit the bone structure of the foot. It usually happens in women more than
Yes.
men, but a lot of the women's shoes may push it
Sure.
into a bunion deformity faster than, like if you're wearing a Birkenstock or something
Sure.
wider.
Right.
So wearing certain shoes can definitely make it progress faster, but a lot of people are going to get it no matter what they wear. So.
Right. Yes. Good old genetics, right?
Yeah, exactly. Yep.
So, what are some minimally invasive options as opposed to maybe open procedures can we talk about for those types of ailments?
There are bunion surgeries that have the old-fashioned way, are large open incisions where we have to make bone cuts to shift the bones and put them in a straightened position, and then close everything up and balance everything. And then there's newer ways of doing it where there's very small incisions made where you get a similar correction, but where you don't disrupt the covering over the bone. So people should have a lot less swelling. They should have less pain.
Okay.
The recovery should be faster.
I like
there
that.
should be less scar tissue with that. Some of the forefoot pain, where it's not so much under the bunion but under the toes, there's procedures where the bones through tiny incisions can be cut. We cut them with a very small burr, and these bones can be allowed to float to a level that makes the whole front part of the foot more balanced without opening it up, without putting pins and screws in. So that's a way of kind of balancing the front part of the foot out without being as invasive. And that the same type of thing can be done with hammer toes to some extent. There's tendon releases that can be done. There's some bone cuts that can be done that can help to realign things without being as invasive as some of the older techniques.
I like that.
Yeah.
I like how it progresses into a way where you try to be less invasive and you try to make it obviously more comfortable for the patient.
Yeah, and there's a lot of, for the younger patients, they may not be as much of a candidate for some of these if the position needs to be absolutely perfect.
I see.
But for some of the lower demand people that may not heal as well, these are definitely great procedures, because a lot of older people or people who have some blood flow issues or skin healing issues
Sure.
for whatever reason, they don't always heal as well. So some of these, the less invasive we can be and still get something corrected, the faster people will heal in general. So we even have those techniques for certain types of broken ankles. There's nails that go up through the bone as opposed to a wide open incision with plates and screws. So there's a broad mix of things that we can do less invasive now than we used to do.
I like that.
Yeah.
Sounds like you stay relevant.
Thank you.
Yeah, because that's what patients want. They don't want the old school way of like the way we imagined it maybe 20 years ago.
Yeah, another advance that we, in addition to specific plates, specific screws for whatever procedure, we also have hardware, pins, screws, staples that are made of materials now that are bioabsorbable or biodegradable.
Yes.
So over the course of 2 years, the implant that is holding whatever work done in place, that turns into bone or dissolves. And so there's basically nothing left behind with some of these newer implants that we use.
Nice. So would you recommend 1 foot at a time to do the surgery if someone has, let's say, bunions?
I think it's almost always advisable.
Okay.
If you are trying to balance walking on both feet that have been operated
Sure,
on,
of course, it doesn't make sense.
one of them is definitely not going to come out as well as you'd like it to. So assuming you want a great outcome, I would almost always do one foot,
Yes.
make sure it's good,
Yeah.
make sure it's healed well, and then address the other one.
What do you think the turnaround time is? Let's say someone says, you know, I'm thinking I'm getting married next year, you know, what should I do? Like, what do you think that turnaround time is for, let's say, bunion surgery?
I mean, for a bunion, usually people can walk immediately after doing a bunion surgery, but to be full activity level and, you know, fully fitting in their shoes, it's usually 3 to 4 months.
Okay.
The biggest part with bunions is that the swelling persists forever.
Oh.
The range of motion comes back pretty quickly. The pain dissipates for some people within just a couple days, other people it takes weeks. But the swelling is usually the thing that prevents people from getting back into whatever footwear they want to wear.
Okay.
And then the
Sure.
bone usually takes 6 weeks or 8 weeks to heal.
Okay.
But for everything else to strengthen, it's probably 3 to 4 months to be realistic.
How long do they have to wear that? Do they have to wear a boot like that?
Usually it's a surgical shoe
A
after
surgical shoe.
most bunion surgeries,
Okay.
which is kind of an unattractive, stiff shoe with a couple Velcro straps
Yeah.
that basically keeps the foot from bending
Sure.
a lot. And that's usually around 6 weeks that they would have
Okay.
to wear that.
Okay.
4 to 6 weeks, but usually 6. Yeah.
So how, like, so I know we spoke, let's say, bunion versus arthritis. What, if it's arthritis, what are some of the procedures that you can offer to the patient if it is arthritis?
Well, so if we're talking about bunions versus arthritis, probably the big thing to realize is the bunion is more of a crooked toe
Okay.
or a toe that has a bump sticking out of the side.
Right.
So a bunion is usually more of a toe that's turning outwards, if you will.
Okay.
Whereas an arthritis issue of the big toe is more pain with up and down motion. Like when you move that big toe up or down, you feel some creaking in the joint,
Yeah.
you feel pain in the joint.
Okay.
So there's sometimes a combination of the two, but usually one is side to side, which is the bunion, and the other one is up and down, which is usually arthritis.
Okay. Question, what if somebody says, I don't want to do the surgery? Do you offer, what type of alternative pain, like to help with pain or discomfort options do you offer?
So for a lot of foot issues, ankle issues, we can get away with doing various corticosteroid injections.
Okay.
Some other different types of injections. There's PRP injections, which is where
tell us about that.
PRP is where you take some blood,
Okay.
and the blood is spun down, and the platelets are taken out of the blood,
Yep.
and they're injected back into the area that's abnormal, and it really works better for tendons
Okay.
or soft tissue issues like plantar fasciitis, Achilles tendonitis. As opposed to joint issues. It really doesn't
Oh, I
work
see.
as well for joint issues.
Okay.
But one of the things with PRP is that if somebody is not really optimized or healthy in the first place,
Yeah,
the PRP is probably not going to work.
I see.
So, you know, if somebody doesn't have a good diet or they're not doing normal
Sure.
things to take care of themselves, you're not going to magically heal something with platelets that are probably not
I
healthy
see.
as well.
Right.
So that's another option.
Getting healthy
but-
first.
Trying to, yeah. And then as far as there are orthotic devices that can
Yeah.
hold the foot in a better position, which can prevent needing any sort of surgery some of the time. It can delay a surgery or prevent it altogether. Some people have problems where, you know, an orthotic is less dangerous than a surgery. With any surgery, there's the 6-week, 8-week downtime. So some
Sure.
people can't or don't have that option to spend that much time recovering.
Okay.
So an orthotic might give them enough support that they can avoid doing that. We have
Okay.
different braces, anything from simple ankle braces up to complicated custom molded braces, depending on how bad an arthritis is or how unstable something is. So there's a lot of options other than surgery.
Okay. We got a quick commercial break. We'll be right back.
Okay.
Everybody stay tuned.
All County Healthcare has exciting news for any and all patients with COPD or other respiratory ailments. Listen to what renowned pulmonologist Dr. Keith Robinson has to say.
Hello, I'm Dr. Keith Robinson, board-certified pulmonologist, medical director at Fusion Health Pulmonary Rehabilitation, and a board member with the American Lung Association of South Florida. We have exciting news for patients with COPD. We now offer IPV therapy at home, which has been demonstrated to improve airway clearance, decrease hospitalization, and improve quality of life of patients with COPD. Please call All County Healthcare for more information about this FDA-approved therapy.
For further information, call All County Healthcare now at 954-717-7027. That is 954-717-7027, or visit our website at allcountyhealthcare.com. You can also find us on Facebook, YouTube, Twitter, Instagram, and LinkedIn. Remember, All County Healthcare always puts the patient's needs first. You are listening to You and Your Doctor, Living Longer and Healthier, an informative show that helps you find answers to questions you always wanted to ask, but did not have that somebody that could make a difference in your life. Call into the show if you have a question at 888-565-1470, and we will put you on the air to inform all our listeners. Now, back to our show.
Thank you, everybody, for tuning back into our show. And we are interviewing today Dr. Kevin Palmer, who is a board-certified foot and ankle surgeon. Phone number is 561-241-4758, and his address is 1905 Clint Moore Road, Suite 105, right here in Boca Raton, Florida, 33496. And just learning so much about, foot and ankle ailments, and, obviously every patient is different, right?
Correct.
But we were discussing bunions, and I know we had a question. I know somebody wanted to know, when should you not do bunion surgery?
Well, so what I would usually say about bunion surgery is that obviously if it's painful enough, and you can't wear normal shoes, you're kind of at that point where you should consider it, assuming you understand how long it takes to heal. You can set that time aside, so you're going to do well. But the other thing is, if the bunion is not painful, but it's continuing to move, if it starts affecting the second toe starts going over the bunion, or it starts to cause a problem with the second toe, I would always try to address it before it affects the second toe, because second toe surgery is never great.
Oh.
It's something you should try to stay away from if you possibly can.
That makes sense.
Because the second toe surgery, it's not just a up and down type deformity. It's up and down, and it's side to side.
I see.
So it's a more complicated deformity, and there's not great solutions for the second toe. So if the bunion is moved enough that it's affecting that, I would definitely try to fix it.
Absolutely.
The other thing is, if the joint is starting to become arthritic, which it can happen if the bunion progresses far enough or is there long enough. Once you have arthritis, which can happen if the bunion progresses enough, then you can't really reverse that.
Makes sense.
So,
yeah.
I mean, you always want to wait as long as you can, but even for bunions, cortisone injections don't really do much. There's splints that can hold it in a better position, but it usually is something that's going to need surgery eventually.
Yeah.
Yeah.
And then going back to the PRP, because I know a lot of the audience members are always looking for that natural way to first option before they do surgery. And you did mention the platelet-rich plasma.
Yeah.
Assuming somebody is healthy, what do you think is an average number of sessions or treatments they would need for that PRP?
Usually people are going to see if the PRP is going to work, which doesn't work for everybody, but if you're going to see improvement, it's usually over about a 4 to 6 week period.
Okay.
They will see a slow decline in symptoms, improvement in pain, whereas with a cortisone injection, which can also be given for tendinitis, tendinosis. So tendinitis is more tendon inflammation.
Okay.
Tendinosis is where there's actual scarring within the tendon, which is kind of a tendinitis that progresses further along. But the PRP will show an improvement over 4 to 6 weeks to some extent, and then it will plateau at some pain area. Whereas a cortisone injection, you'll get quick relief of pain, assuming it works.
Yes.
Quick relief of pain, but then that wears off over anywhere from 3 months up to a year or more, depends on each person.
Right.
But the PRP can always be repeated a number of times.
Good.
There's no harm in doing it 2, 3 or more times. It's generally not covered by insurance, so there is a cost associated with that. Cortisone injections for tendons usually should be done maybe 3 times in a year.
Okay.
And you don't want to continue doing them because they can weaken tendons to the point where it could rupture or it could become weaker, where you'll need surgery. For some arthritis, you can continue to do injections indefinitely. You don't want to do them every week, but every 3 months or so. And if a joint is already arthritic, it's not going to get a lot worse. Cortisone can damage cartilage. It can damage the joint. So if it's really an inflammation of the joint, it'll calm the inflammation down, calm the pain down. But if it's already arthritic, there's no reason not to do it. If it provides pain, you can avoid surgery. Even if the joint looks terrible, there's no reason not to do it.
Makes sense. I was going to ask you, doctor, what is the demographic of patients that come to see you at the practice?
So this practice, there are a large number of older athletes.
Nice.
50, 60, up to 85, 90. Playing tennis, golf, different Florida sports. But we also have some younger patients. I've seen as young as 3-year-old patient. Usually it's more an adult population though. Yeah.
Good to know. So stress fracture versus a true fracture. Can you explain the distinction?
Yeah, so we get a lot of questions. People will ask, is it a break or is it a fracture?
Yeah, what's that distinction?
It's really 2 different terms for the same thing, similar to like, is it a bone bruise or is it a contusion? Which is like a fancier word for the same type of thing. So a fracture is like when something is truly broken, which you see on the x-ray, there's a line where there's a crack in the bone, versus a stress fracture is something that you can't necessarily see on an x-ray. So from repetitive stress or walking too much, you will start getting some weakening in the bone. Sometimes after about 2 weeks, it'll show up on an x-ray with a cloud around the bone where it's weakened. Sometimes it won't show up on an x-ray at all, and you'll need an MRI to see bone swelling. You'll see a bunch of bone bruising, bone swelling, and if it's enough bone swelling, they call it a stress fracture. And a stress fracture should heal on its own, but it takes 6-8 weeks. So if you don't know it's a stress fracture, it can turn into a true fracture.
I see.
It can turn into a true break because the bone's weakened. And then there's the question of which breaks need to be fixed versus not fixed. And that will depend on the patient, depends on which bone it is, depends on how the bone heals. And each bone and each patient brings a little different perspective to whether you go down this road or that road.
That's why they have to see you, Dr. Palmer. We're talking all here, just you know,
broad,
we're just giving different scenarios. But I want to just plug you again. So if anybody's listening and you have a friend or family member that needs to see, you know, a foot and ankle surgeon, please call 561-241-4758. Because really, everyone's so different, right?
Correct. Yeah.
Somebody could have a same break, but maybe have a different experience of the healing process. And we actually have 2 minutes left, so let's talk the next 2 minutes of whatever you'd like to
I guess discuss. One thing that we didn't touch on that I'd love to bring up is nerve pain, neuroma pain is a very common issue, which is where in the front part of the foot, one of the
Yeah.
nerves gets pinched between the two bones,
Yeah.
and it is from trauma, and the pathology is inflammation around the nerve. It's a really common issue. Runners, athletes, a lot of people get it. Most of the time, people do well with cortisone injections only. Calms down the inflammation, they feel better. But there is a surgery for that if it doesn't get better, which most people don't need. But the traditional way of doing it is making an incision and cutting the nerve out.
Oh, wow.
And I think most people still do it that way.
Okay.
And since I got into practice, I've seen a paper that described just releasing the ligament over it. It opens up the space, lets the nerve heal on its own.
Oh, okay.
Much like what's done with a carpal tunnel. A small
Yes.
incision is made, they release a ligament.
Got it.
They don't cut out the nerve that goes to the
Oh.
hand. And it's the same idea with that,
Makes
is that
sense.
we open it up, we release it. So I would encourage anybody who's listening, if somebody wants to cut your nerves out, maybe get another opinion.
Absolutely.
Because it's one of those things that is probably not necessary
Yeah.
that a lot of us do
Right.
because of our training.
Yeah.
So,
Well, thank you for staying relevant
Thank you.
and always learning what other options are out there because people want options. So thank you
Thank you.
so much for coming on the show. We appreciate you.
Thank you.
Take care.
Thank you for having me.
Absolutely.
Appreciate it.
Absolutely.